Hi, I'm Dr. Sunny Hatch. I'm a faculty scholar in the John P. McGovern Academy of Oslerian Medicine. I'll be continuing our discussion today of Care Carefully, Chapter 6 in the book by Dr. Charles Bryan, Osler Inspirations from a Great Physician. I'm honored to be joined by Dr. Joan Richardson. She is scholar in the Academy, chair of pediatrics, and director of the Division of Neonatology at UTMB. So the first question I have for you, Joan, are doctors obligated to be caring, concerned, compassionate?
Well, I believe they certainly are. I think they certainly are obligated to be caring and concerned and compassionate. I don't know who said this. I think it may have been Osler, but one of the obligations of physicians are to cure sometimes, to relieve pain often, but to comfort always. And I think that goes with the territory. That's part of the deal when you sign on as a physician.
You know, Osler's been described as actually the least sentimental and the most helpful man ever seen, and also the most lovable. And it seems that there are many examples of carrying through his actions. Do you remember the one with the child with a severe whooping cough complicated by bronchitis?
Well, that's a wonderful story, and it occurred when he was Regis Professor of Medicine at Oxford, and he was on his way to confer degrees at graduation. But he had promised a friend that he would stop by and see his child, check on his child who had whooping cough. So Osler, as always, was in a hurry to get everywhere. So he arrived at the child's house in his academic regalia, which, if you've ever seen it, it's on display at his home at Oxford. It's sort of a crimson red robe with a black hat with a tassel. So he arrived at this child's home dressed in his academic regalia. And coincidentally, that turned out really well because that really impressed the child. And I guess the child thought that, Father Christmas was coming or somebody was coming who was very special to see him. So he listened to what Osler said. Osler sat down by his bed, and the child was sick. He was not eating well. And Osler took out a peach and pared the peach, cut it in pairs, and sugared it, and gave it to the child and said, eat this, it'll make you feel better. And the child ate it. And then Osler had to run away and go to his graduation ceremonies. But he came back to see the child every day for the next 30 or so days. But he always donned his academic regalia before he entered the kiddo's room, and gave him a peach, and the child ate the peach, and gradually the child recovered and got okay. However, Osler, on his first visit, was very pessimistic to the father and said something like, hey, things don't look too good. These children never do very well. But in fact, the child did recover. And I think that's an incredible example of caring and compassion and interest in one's patients.
He went the extra mile, didn't he, and everything. But he had a way of touching. He touched the lives of patients, and he touched the lives of the families. Can you talk to us about touch in the NICU?
Well, the NICU is a pretty intimidating place. There's it's packed with all this equipment and machinery and monitors, and it's for people who aren't really familiar with it, it's like being in a space capsule or something like that. And one of the things that I try to do when I round on the babies is always to touch them, to examine them, to pat them if they're crying, to pat them and try to calm them down. But also, I think when there are families there, visiting their babies, staying with their babies, and some families come in and stay for hours at their baby's bedside, even though they're not able to do anything except be present. I think it's very important to talk to the family, but I don't think it's a good idea to stand up and talk to the family. I think the most effective thing is to sit down and push your chair up close to the family and give them a chance to tell you what they think is going on with the baby, how they think the baby's doing, and then give them an update on how things are doing with the baby. I think that when you go into our unit and you wander around, you will see the nurses constantly touching or comforting the babies. It's a very important part of their connection with these little sick creatures.
You know, you did mention something when Osler left the bedside of the child, and he discussed with the father that the predicted outcome was not good for his child. But in general, he embraced that you need to always leave with a word of encouragement. Is that right?
I think that's true. I think that it's one should really never take away hope. I think someone told me a long time ago that in talking with families, talking with parents, share your knowledge with your patients, but keep your doubts to yourself. In other words, you may have some grave doubts about how well things are going to turn out, but you don't really need to share that. What I think the family is interested in is what's wrong with my baby and what are you going to do right now? What are you going to do today? I think that for me, that was good advice. Share your knowledge with your patients, but keep your doubts to yourself.
He recognized the role of sympathy and charity in medicine, and in fact, the Oslerian tradition of humanism underlies the concept of death with dignity. So, in the ICU, you are actively considering the dignity of the infant as well as the parent, I'm sure. But do you feel that the medical technology and the advanced life support or life-saving techniques impinge upon death with dignity?
I think they can. I don't think that they have to. And I think we're seeing that to a great extent in the current COVID pandemic, where patients are very, very sick in intensive care units, on ventilators, and for many, many reasons, infection control reasons, the families are not really allowed to be there except by iPhone or iPad. So I think in some instances that does interfere. It doesn't have to. Let me give you an example. Even though we may have a baby in the NICU who is intubated and on a respirator with IVs going and hooked up to all sorts of monitors, we think it's very, very important to put that baby in their mother's arms and let the mother hold the baby for a while. And it may take 2 or 3 people to get the baby safely transferred into the arms of the mother. but it can be done. It can be done. If there's a will, there's a way. And it's interesting to me what happens when babies get into the arms of their mom or their dad and are held. It's an amazing thing that happens. Oftentimes their heart rate goes down. They look much more comfortable. Their blood oxygen level goes up. Very, very strange things happen. So, again, I think that, yes, those high-tech things can interfere with things, but they don't have to.
Osler felt that charity to be essential in the practice of medicine. And in fact, one of his writings, he states, our fellow creatures cannot be dealt with as man deals in corn and coal. The human heart by which we live must control our professional relations. He felt that the profession of medicine is distinguished by all others by singular beneficence. A contemporary described his unspoken motto as to do the right thing and to do it first. And you have trainees. And I wondered, how do you convey that to a trainee, to do the right thing and to do it first?
Well, I think actions speak louder than words. And talk is cheap. I'm into behaviors. I think the best way I can teach my trainees to behave in that way is to behave in that way myself, and hopefully they'll model that behavior.
Osler always talks about, in his writings, about including equanimitas, the control of our emotions. How do you control your emotions? Do you make a conscious effort?
Well, I don't really think I control my emotions too well. One of the things that I do try to do is not let my emotions get in the way of doing the job that I need to do. And moreover, not let my emotions get in the way of somebody else doing their job. So what happens if you get angry or frustrated and you yell at someone is all of a sudden they're not going to perform as well as they could. So I have spent a lot of time and a lot of years trying to keep my emotions under control. By the same token, I don't see any problem if you're talking with a family and things are really not looking very well, and the family begins to cry and you feel like crying. I don't see anything wrong with your crying with the family. I don't really think that's a breach of any sort of professional anything. And you just can't let your emotions get in the way of doing your job. And somehow or another, you've got to keep that under control.
In your field, I would think that the family is very important as far as the continuity of care after after your child or infant is discharged.
Well, yes, it is. For the babies who are in the NICU for a long period of time, as you might imagine, they develop a pretty close connection with the physicians as well as many of the nurses who take care of them. And we do stay in touch. Every year, October or so, we have what we call our preemie reunion, where older preemies and maybe not so old preemies come back, and we get together out here on the lawn at UTMB and check on each other and see how things are going. Our families send us pictures. May is my favorite month of the year because in May I start getting graduation invitations from babies who are now graduating from high school, and off in college, who I took care of. I've been doing this for a long time now, and so not only have I taken care of babies, but I've taken care of my baby's babies. But that really is one of my favorite times of the year, because they somehow or another don't forget me, and they know they can always find me at UTMB. And so we don't really ever get out of each other's lives.
When the infant is ready to go home, how do you assess is the home ready, but also the competency of the parent to take care of the child?
Well, fortunately, we have a plan. It's our patient education plan. We have nurses who specialize in discharge planning. We have the families in. They spend a lot of time learning how to do basic care of the baby. If the baby has certain problems, we'll actually have the mother and dad come and stay a few days in the hospital with the baby so they can learn how to take care of the baby. And there are certain skills that they need to demonstrate that they can do before we let the baby go home. And that may be something as simple as drawing up the medication and giving the baby the medicine, feeding the baby, understanding how to give a bath, how to change the diaper or whatever. And then some of our babies who have more complex problems, like I said, we'll have the mother and father come and stay with us for a few days and get checked off in their ability to do that. Sometimes things don't work out, and at that point we involve state agencies to help us find a place for the baby. That's very unusual, but it does happen. We spend a lot of time, I think, on parent education, and hopefully they view it as a partnership, that they're in partnership with us in terms of doing what's best for the baby.
Let's skip for a minute into something that Osler thought, and he demonstrated through his actions that all patients need to receive equal treatment regardless of their socioeconomic status. You have an administrative role, obviously. And how does that factor into how you practice medicine?
Well, fortunately, I've never been placed in the position, nor have I allowed myself to get put in a position where I've denied care to anybody based on ability to pay or anything like that. If a baby is sick and a baby needs care, the baby's going to get what they need. We try to practice good, solid, responsible care to all of our patients, no matter what their socioeconomic status is, because I think we owe that to everyone. But I don't think I would be able to withhold care based on someone's ability to pay.
Oddly, Osler recognized burnout even during his time. And it's become very much a topic of the physician and how they're perceived and how they perceive their life right now. How do you think doctors should care for themselves to prevent burnout?
Well, I think the first thing is to come clean and admit that even you, a physician, can burn out, and take steps to think about other things than the practice of your profession. I believe, pay attention to that in neonatology, because when you're on service in the NICU, it's fast-paced, it's busy, there are many disruptions. You can be up late at night or all night or whatever, and you can't continue that pace for an extended period of time. So we limit the number of consecutive days that we're on service in the NICU, and then you get off and you recover or do something else. We also have a call schedule where the neonatologists take call at night, so the person who's on attending in the NICU is not on call 24/7 for 10 days. So they do get a break. I think the other thing, too, that we try to do is support each other, be available to let people vent when things don't go well or they've got a problem, and talk about some of the issues that they've had. Burnout is common. It happens to everybody. Everybody's at risk for it, and we try to ward it off as much as possible.
Osler had a sense of humor, and he thought that was very important to avoid burnout. He was known for playing with the children. I guess he was very childlike at times when he played with them, huh?
A sense of humor is good for just about everything, and I think you really need that if you're going to hang around kids, and you also need some sort of I don't know, what is it? Not all small children are not small adults, but all adults should be really small children.
I like that. So Osler's style of caring may not be appropriate for all of us, but it does illustrate the value of finding ways to care that are beneficial and sensitive, yet realistic and within one's capacity. For Osler, the essence of caring was a love of medicine combined with a love of humanity. He was relevant yesterday, he is relevant today, and hopefully will continue to be relevant tomorrow. He loved teaching medical students, and this is what he said to the medical student. The motto of each of you as you undertake the examination and treatment of a case should be put yourself in his place. Realize, so far as you can, the mental state of the patient, enter into his feelings, scan gently his faults, the kindly word, the cheerful greeting, the sympathetic look. Thank you for listening to our discussion. And as always, remember to practice medicine with your head, your heart, and your hands.
UTMB Health, working together to work wonders.